As a dentist, I'm constantly looking in people's mouths, and every mouth tells me a different story.
When someone engages in certain types of unhealthy and destructive eating behaviours, the signs in the mouth can be pretty clear that something is going on.
There is obviously a lot of psychology in there that I think we as dentists are not trained to pick up, but failure to recognise the complications of these mental illnesses may have serious, if not morbid, consequences.
Through all my years of experience, I've learnt that there is no one-size-fits-all when it comes to patients who suffer from these disorders.
We can't buy into the typical stereotypes, that it's only white women or teenage girls living in Western society, or that it's attention-seeking behaviour or a diet gone wrong or whatever. But what we do know is that there are some people more at risk than others. Children and adolescents, for example, or women at key life transitions such as puberty or pregnancy or menopause. Also, people that are on a diet or seeking help for weight loss, and people engaged in competitive or athletic sports like gymnastics or ballet are more at risk too.
Oral practitioners need to be acutely aware of the signs and symptoms of these illnesses and recognise their adverse effects on systemic and dental health.
I have a duty to make the care of my patients my primary concern. I never want to jump to any conclusions about someone and what they may or may not be doing to themselves. So I always try to understand the facts about the patient first.
If we are looking at the orofacial manifestations, we're really talking about the effects of restrictive eating or self-starvation, or binge eating followed by purging or vomiting.
In patients with eating disorders, we may see enlarged parotid glands and low saliva flow caused by chronic dehydration. That could result in dryness and cracking of the buccal mucosa, chapped or cracked lips, and dry gingival tissues that become painful to touch.
The most commonly observed complication for self-induced vomiting is dental erosion. Of course, there are degrees of erosion which can be classified as mild, moderate or severe, depending on how long and how often someone has purging episodes. But ultimately, as it continues, the provision of dental care gets more complicated, particularly when young individuals are involved.
Dental problems resulting from purging behaviours can appear as early as 6 months after onset. With a lot of vomiting, you can become dehydrated, which can cause salivary dysfunction resulting in a sore throat, dry mouth or burning tongue.
For patients with mild erosion, usually in the early stages of their eating disorder, the affected teeth are often asymptomatic. You might see a slight loss of the superficial enamel layer from the palatal surfaces of the maxillary anterior teeth, but not much more. However, without intervention as the disease progresses, perhaps 5 years or more, you get a definite loss of enamel and exposure of the dentine of those teeth, plus moderate enamel loss on the palatal and occlusal surfaces of upper molars and lingual surfaces of lower posterior teeth. Then, in severe cases where regular purging has occurred for a decade or more, you see extensive loss of enamel and dentine on the lingual, palatal, incisal and occlusal surfaces of the anterior and posterior segments of both arches.
We see translucent chipped or notched maxillary incisors, bleeding gingiva or gingival recession, V-shaped lesions on labial aspect of teeth as a result of vigorous or frequent brushing following episodes of purging. We see trauma to mucosal membranes, including the pharynx and soft palate, and sensitivity to hot and cold foods. The list is quite extensive.
Look, it's hard to know whether someone has been engaging in self-induced vomiting or whether they have an undiagnosed reflux condition. So once I become aware of the state of their oral health, I need to initiate a conversation with them. This can, of course, be a challenging issue to raise with a patient, so I do my very best to make them feel supported and not intimidated.
I always discuss these matters privately without others around, in a kind and non-judgmental way. I will start by saying, I've noticed a few problems with your teeth, and then tell them what it is that I've seen. So I go on to explain that these problems can be associated with either vomiting or reflux. In the case of acid erosion, or if I suspect self-starvation, I'll talk about the signs in the mouth relating to dehydration or malnutrition if evident. And then, depending on their reaction, I may ask them directly, do you make yourself vomit regularly? Or are you trying to diet or cut out foods?
It helps to be positive in your approach and to assure your patient that you have enough time to talk through things. It's best to ask questions in a non-judgmental way, aimed simply at encouraging your patient to identify the origins of their oral health problems. One way that can help in this endeavour is to share your examination findings with your patient and explain how their symptoms may be linked.
This could be the first time your patient has actually said anything to anyone about their illness. And so it's essential to really create a positive experience for them. That way they're more likely to engage successfully with future treatment and probably like going to the dentist a whole lot more.
If they are actually willing to talk about their problem, I'll commend them and say, I understand how difficult this is, or I'm really glad you're talking to me about this.
Reassurance also helps, letting your patient know that they are not alone and that eating problems are common.
I would never be critical, never comment on their weight, appearance or health in general in any way, and I certainly never offer any quick fixes.
Patients react in a variety of ways. They can become irritated, emotional or defensive. I never take their response personally. Instead, I keep supporting them, encourage help seeking and give them some advice on how best to improve or maintain their overall dental health.
If they deny they have an eating issue, I don't push it. I accept their answer and focus on maintaining or restoring their oral health as best I can under the circumstances. For example, I may talk about some methods for reducing the effects of acidic foods and drinks.
If the patient's teeth or gums are in poor health, you will need to treat them to prevent further damage developing. In these cases, dental care will be most effective when performed after the patient is treated for their eating disorder and when destructive eating behaviours have either ceased or significantly lessened.
If I suspect an eating problem may be present, I refer the patient to an experienced eating disorder clinician. I think it's essential that they talk to an expert in the field. I let them know that treatment can be very effective and can lead to a full recovery.
I refer the patient to their GP. GPs are great because they can play a key coordination role in the care team.
A GP can manage input from psychologists, dietitians, occupational therapists, etc.
At our clinic, we have a bunch of fact sheets from the NEDC and other local eating disorder services with information and resources about eating disorders that we keep in the waiting room.
There's no reason why you can't call the Butterfly National Helpline together or even use their support service yourself as a clinician. Their counsellors can help talk through your concerns about your patient and develop a plan for what to do next.
We can also offer to help the patient find a clinician or psychologist if they like and make the appropriate calls on their behalf.
No matter what my patient decides to do, I always let them know that I will continue to care for their dental needs and I encourage them to return regularly for oral checkups and treatments.
Managing patients who suffer from mental illnesses can bring up a lot of insecurities in a dentist. Not knowing the right thing to say, am I going to upset or lose them? Will I cause more harm than good? But what I say is, don't be scared to open your mouth and say something to your patient. You could be saving a life.